Good afternoon and welcome to our webinar on SARS-CoV-2 and assisted reproduction in 2021. If you have any questions during this webinar, you can use the slido.com website, and I have shown and I will be showing the access code, which is COVID ART 0512 for entering any questions. I will now give the word to Dr. Ana Vega, who is the moderator of today's webinar.
Thank you, Natalie. Thank you everybody for being here with us, especially the speakers. Let me first tell you about the working group that in fact organized this webinar together with the central office at ESRE. And this working group was initiated his responsibilities early in the pandemic, more than 1 year from now. And the aims of this working group are to guide the practice in ART during the pandemic. We have produced a number of guidance documents, in fact 5, and 3 articles published in different journals. We have made different collaborations with sister societies such as the IFFS and the ASRM to try to provide these guidance documents for the patients and also for the professionals. Our aim is also to support patients and professionals during the pandemic, to try to help them in doing their job and in being treated in these difficult circumstances. Also, we have tried to increase knowledge by doing different initiatives, by having a survey on pregnancy and COVID to try to understand or to find out if COVID infection was worse in the case of ART pregnancies, especially in the first trimester. We have gathered some data that will be soon available. And finally, let me tell you that we have also promoted a grant. ESRE has a research grant that is put in place every year to try to collect and to provide money funding for research projects related to reproduction. And in this case, it was allocated to COVID and reproduction, and the projects have already been granted, and we are happy that we have had a very good welcome to this grant. This webinar is intended to provide knowledge in SARS-CoV-2 and assisted reproduction. We will focus more on the idea of the vaccination, but we will also have certain data provided by the speakers that we have today. That will give us data with respect to infection in pregnancy and how is it being different than people that are not pregnant. We will also have the experience of the patients during the COVID-19 pandemic, and I would like to thank Fertility Europe, who is also part of our working group, to suggest somebody, in this case Andrea Brugic, to be here with us. It's important that we hear the voice of the patients to try to be nicer with them, even more than we are in these difficult times. And finally, one of the members of the group, in this case, Dr. Edgar Mocanu, will give you an insight of how ART services have adapted to this situation. Without delay, let me first introduce the first speaker. The first speaker is Kari Johansen. She will give us a presentation on vaccines and vaccination, especially focusing on what we are dealing with. Kari Johansen is an independent health expert. She was a former ECDC, European Center for Disease Control, and the Swedish Public Health Institute. And we are looking forward to trying to understand more about the COVID vaccines and vaccination. So the floor is yours. Thank you for being with us, and thank you for sharing your knowledge with us. Thank you.
Thank you very much for the invitation. Can you hear me?
Yes.
Wonderful. Can you also see me? Because I don't see my picture.
Yes, yes, we can see. We can see the slides.
And can you see me also? No?
No, no.
No.
Maybe that's not important. I'll go ahead, I think, with my presentation. Yes, maybe now. Can you see me now?
Now
Okay.
we can.
Good.
Now it's perfect.
Thank you very much for the invitation. I'm a pediatrician and a clinical virologist. I have worked for the last 12 and a half years for European CDC, and before that for 8 years at the Swedish Public Health Institute. And I am in the middle of contracts due to age. I retired end of March. That's why I'm defined as independent public health expert. But now you have a picture of me. I'm really looking forward to listen to your discussions today, because this is an area we know very little about, and ECDC has never worked in this area really. So I'm looking forward to understand a bit more. So the topic given to me was COVID-19 vaccines and vaccination, and these are electron microscopy pictures of SARS-CoV-2. And I'm using them because I used to lead a group in Sweden that owned the only electron microscope in Sweden. So I think it's nicer to see the real virus. And you know, whatever I will say, there are new variants of this SARS-CoV-2 virus, and they will impact vaccines and vaccination probably to a large extent, but we don't know exactly how, and that is currently very much under discussion. So next slide, please. So I just want to touch a little bit upon the EU authorized vaccines, the vaccine production technologies, a few words about vaccine coverage, vaccine effectiveness, and vaccine safety. I think each one of them will have some relevance for you. Next slide, please. So first, an overview slide of the vaccine production technologies. This is the first publication in Nature Reviews that came out April 9th last year. And several of the authors of this article are from CEPI, CEPI being one of the large funders of these vaccines. And as you see, there are many technologies. You recognize some of them, like live attenuated virus, where we have measles vaccines, we have rubella vaccines, we have intranasal vaccines for influenza. So it's not a new technology. Also, the inactivated vaccines are a well-known technology where you usually use formaldehyde to inactivate. But then we come to the viral vectors. There are both non-replicating and replicating viral vector vaccines. And we are only going to take a look at the non-replicating because that's what we have available to us right now. And then we have recombinant proteins or protein-based vaccines in general. And then the big unknowns, the RNA vaccines that we are still learning so much. So this is where we were April a year ago. You see how few vaccines there were in phase 1. But if you move to next slide, please. You see we have 4 vaccines currently authorized in the European Union. Messenger RNA from BioNTech, developed by BioNTech, which initially is, they had a number of mRNA products, but in the cancer field, and they have teamed up with Pfizer, a large vaccine producer in the world. And then we have Moderna, that has an mRNA vaccine that have worked very closely with NIH, National Institute of Health in the US, and conducted their trials. Then we have Oxford University that have developed a vector-based vaccine, and they have, after signing agreements with, interestingly, almost 20 vaccine producers across the world, they signed up and teamed up with AstraZeneca. And then finally, the Janssen is also a well-known vaccine producer, and they also have an adenovirus vector-based vaccine. So next slide, please. So I've just mentioned that these are the three main technologies that are moving forward: the non-replicating viral vector, the recombinant protein and peptide-based, and the RNA vaccines. Next slide, please. Could you push one more and see what happens? Yes, so this is the technology behind the messenger RNA. So what you really only need is the sequence, the genetic sequence. And the genetic sequence was published 11th of January 2020. And that's the time point when the messenger RNA developers could start delivering and producing and delivering vaccines to us. And the first vaccine that became available to us was the messenger RNA technology. Next slide, please. So we have two on the market in the EU. I presume most of the audience are from the EU. I hope I'm right there. There are many advantages to the messenger RNA vaccines. They are rapid to produce, as we also now have evidence to see. They have so far been safe and non-toxic. And before any vaccine is authorized in the European Union, they have to go through reproductive and toxicity studies in animals that EMA will review. They are non-infectious, they are non-integrating, they degrade in 2 to 3 days. And the antigen, meaning the spike protein, the outer surface protein, is expressed intracellularly, so the body can recognize it easily. It does not induce any vector-specific immunity that you will see the others, the adenovirus vector vaccines do. And repeated immunizations are possible. And I think you know from the media that both BioNTech and Moderna are producing updated vaccines that possibly will be used as booster doses. And I have heard different time points when these vaccines will become available, anywhere between September and December, depending on you ask, so I don't know where the truth is. But there are some disadvantages that I would like to highlight to you, because you work in a very sensitive area, and that is that these mRNA vaccines has never ever been licensed in humans. And the youngest individual that have so far received in clinical trials is 12 years old, although studies have started in 5 to 11-year-olds and also 2 to 5-year-olds. And the goal is for the producers, both companies here, to go down to 6 months. I have not seen very much on any trials. Well, there are trials also that were initiated in January in pregnant women, but I have not seen any data from them. So there's one difficulty which is possible to overcome in the region of the world we work, that especially the BioNTech Pfizer vaccine need ultra cold storage down to -70 degrees. Next slide, please. please skip that one. That should have been gone for some, I don't know why it's there. Okay, so the next one is adenovirus vectored vaccines. And there are different adenoviruses being used in these vaccines. Janssen use human adenoviruses, and the Oxford University use chimpanzee adenoviruses. And I think you may know that also Sputnik V, the Russian vaccine from Gamaleya, they also have an adenovirus vectored vaccine. So the advantages of this technology is that it's well established, meaning that it has been used in the Ebola vaccines, but there's not extensive use, especially not in the European Union. The other advantage is that it induces strong both B and T cell immunity. It's also thermostable, which is fantastic when you are to roll out vaccines to every citizen on this earth. It's scalable in production, and it's a very low cost, about a fifth of the messenger RNA vaccines. So that is also incredibly important. And Oxford University, for example, have transferred the technology to the Serum Institute of India. So they are producing a similar vaccine as being produced in the EU. And that is now being produced, delivered in India, and has, before the big crisis with the new variant in India, also been exported to many other parts of the world, including Africa. So the disadvantage is that the previous exposure to the vector could reduce effectiveness. This is not certain, as Oxford AstraZeneca thought they could use the same vector, and I think they're still hoping to do that, but I know they've also been in contact with Gamaleya, the Sputnik V producer. And they're relatively complex to manufacture. Next slide, please. So the third group I want to touch upon is the adjuvanted protein subunit, and there are several words here. They are protein subunit, and those are vaccines that we are commonly quite used to, but they're also adjuvanted. And the two vaccines, or the two developers, Novavax, and there's a joint venture between Sanofi and GSK, they use different adjuvants. Every time you mix an adjuvant with a new protein, it's really a new product. So it has to be carefully studied, and they are on, Novavax is under, they expect to file with the European Medicines Agency. We actually expected them to file already Q2, but media has said in the last 2 days that they will only file in Q3. And Sanofi Pasteur and GSK, they had difficulties with their first product, so they are even more behind. So these are two vaccines that will be a bit later. Next slide, please. So the advantages for these are that the well-established technology, suitable for people with compromised immune system, which could be a big advantage. We have large populations in the European Union undergoing treatments of different kinds. There are no live components, so no risk to trigger disease, and they're relatively stable. Disadvantage is that they are relatively complex to manufacturers, and again, booster doses may be required, and the best antigen combination may take some time. Next slide, please. So a few words about vaccine coverage. Countries are moving along. In general, we have in the EU received much less vaccine than there were contracts from, and worst to deliver has AstraZeneca been. They've only delivered about 30% of what the contract said. And you've seen that the European Commission, I think they are now taking legal actions against that. But most countries are now reaching above 30% of the population that have received dose 1. And there are fewer that have received dose 2. And following the United Kingdom, that moved the space from 4 weeks between the dose 1 and 2 up to 12 weeks, and even up to 16 weeks have been discussed, are now being evaluated, and people or countries are holding off on dose 2 to make as many people as possible to receive dose 1. Next slide, please. Just a few words about vaccine effectiveness. There are both RCTs for these studies that are the basis for the authorization, but there are also effectiveness studies coming along. And against symptomatic disease, in the live systematic review that is being conducted with the Robert Koch Institute in Germany and ECDC, and it will, I hope within a week's time, be up and running on the ECDC website. You can see an effectiveness against a symptomatic disease ranging from 64 to 94% in the observational studies. And the ones that have the lowest effectiveness are in the oldest people. So long-term care facilities, for example. When you look at asymptomatic disease after dose 2, it's actually looking quite good. We have had a lot of worry for transmission among vaccinated people. So vaccinated individuals starting to move around in the society, that they can be carriers, but it's looking quite good. Next slide, please. I just wanted to say a few words about the thromboembolic events that have been investigated lately, because they may be important to you. And they have only or mainly been reported with the AstraZeneca vaccine. There are a few reports from the Janssen vaccine as well. The rate varies between Norway, 1 in 25,000 vaccinated, to in England, 1 in 250,000. So there seems to be a difference, and EMA often speak of 1 in 100,000, and they base that on an average, but many more investigations are needed. But meanwhile, the Pharmacovigilance Risk Assessment Committee at EMA, they have made significant inquiries into the countries that have reported the cases, and they have so far said vaccines benefits currently still outweigh the risk. I think you are aware that countries are, so each country has a national immunization technical advisory group, and these data are being discussed. And some of the European countries are taking different approaches to whether they will continue to administer AstraZeneca vaccines long-term for different age groups. And I do think it may be so that the European Commission will not renew the contract with AstraZeneca. So I think that was the last slide for me. I think there's a last one just saying thank you, and I'm happy to take any questions. At least I don't hear you, Anna.
Yes, I'm here. Sorry, I was unmuting myself. Thank you so much. Thank you, Kari. That was an excellent talk that gives us information that we lack most of the times. I think that we will have the questions at the end of the whole presentation. So now it's time to introduce the next speaker. The next speaker is Dr. Ashley Moffat. Ashley Moffat is an expert in placentation in the Department of Pathology at the University of Cambridge. She's also expert in reproductive immunology in placental organoids. So we have the pleasure to have her here with information regarding the vertical transmission of the virus. This has been discussed in different papers. We will listen very carefully to you because we still do not know if this vertical transmission really exists or is extremely rare. And we are looking forward to seeing what your data say and what we can recommend, especially to our patients, and to give that useful information. So the title of the talk is Vertical Transmissions of SARS-CoV-2 and SARS-CoV-2 Antibodies. And the floor is yours, Ashley. Thank you for coming. We cannot hear you.
Read it. There we are.
Now, thank you.
Sorry, apologies. So I was asked to talk about the vertical transmission of SARS, but of course I thought, well, I don't really know anything about it. But then I thought, well, actually nobody really knows anything about it. So maybe I can have a think about this possibility. So next slide. Next slide, please. Sorry. And I think the very first report actually came from the UK, where they had a prospective study of all obstetric units in the country, starting last March, and this study highlighted that 5% of infants of infected mothers were positive. And in subsequent studies, it has been around that figure of about that figure have had positive RT-PCR for viral RNA. But does this mean vertical transmission or not? This is the question. So next slide. We have to think, how do neonates become infected? And it's basically two routes. So either this is before birth, when the pathogens can cross the placental barrier, or less likely, actually, this is only much later, there can be an ascending infection via the cervix, or the infection is acquired during birth or postnatally from breast milk. And of course, the baby at birth is in contact with many secretions and blood, which are potentially containing the pathogen. Next slide. Now, the pathogens that do cause congenital infection that cross the placenta are from every group of organism, protozoa, bacteria, and viruses, many viruses, in fact. I would say here that I think that there is one feature that they may share, which is the ones that cross, which is that they can survive in macrophages, and other pathogens like flu and malaria do not. Next slide. So let's look at how this might work. So here is the interface, this barrier between the mother and the fetus with the placenta. And you can see in blue here is the fetal placenta with the villi, with the maternal blood in the intervillous space. And there is, of course, invasion of the trophoblast placental cells deep into the decidua to transform these spiral arteries. Now, how can these pathogens get across? Next slide. And this is disputed, and I think it's rather extraordinary that we really don't know what is the route. It could be, and for many people feel that it actually crosses from the decidua into the invading trophoblast. But I feel myself that it's much more likely that mostly the pathogens cross from the blood across the syncytium in the placental villi. But there are some pathogens like listeria which can move between cell to cell, which might come from the decidua. Next slide. Whichever way they cross, from the decidua into the extravillus or from the blood into the villi, you have to have virus in the blood. And one of the features about SARS is that actually the viral loads in the blood are quite low. The highest viral loads are in the sputum and the nasopharyngeal tract. And when you look at the viral loads that are in blood, the next slide, these are really in people who are very sick, who are ventilated or have a nasal cannulus. And for those people who are not very sick with the virus, the chances of it being in the blood are quite low. So this means that if it is going to be vertically transmitted, it's going to be the women who are very sick and probably on a ventilator. Next slide. So the next question is that if it is indeed in the blood, does the syncytium, this barrier between the intervillar space and the blood there, express both the ACE2 and the co-receptor necessary for entry into a cell? And this has been very controversial because people have really mainly looked for mRNA for ACE2 in the trophoblast. But there is a recent paper, which is the next slide, where it has actually looked by immunohistology for the protein. And I just want to highlight here how the villi change very dramatically from the first trimester at the top there to a term. So you can see incredible thinning of the trophoblast layer as we become near a term. And when you look at where this protein is expressed, next slide, but what is striking is that it does seem to change throughout gestation, and it's highest in the first trimester and then drops by term in the control. But it seems that in women who have an infection, then it actually may be upregulated in the trophoblast. It does also seem to be expressed in the extravillus. But having said that, the co-receptor does not appear to be expressed, and that seems to be pretty well agreed by most groups. Next slide. Now, this receptor is therefore on the trophoblast, so it means that the virus could stick to the trophoblast, even though it wouldn't be able to access the cells because it lacks the co-receptor. And there have been reports of this, of quite dramatic placental pathology. Again, this is generally in very sick women, where we see this fibrin in the intervillar space. And this is, of course, associated probably with a thrombotic tendency we see in these patients. Next slide. There is also rare cases where we actually see very profound influx of inflammatory cells in the intervillar space. And this is actually rather similar to the appearance that you see in placental malaria, where again, there is not transmission across the placenta, but placental malaria can cause this profound inflammation, causing a syndrome very similar to preeclampsia because it's stressing the trophoblast cells. Next slide. So other possible ways, and I mean, I'm thinking when I was reflecting on this, it's amazing that we still really don't know so much about congenital infection. But another way that people have suggested that pathogens might cross is actually with attached to antibodies, because of course the antibodies that cross the placenta are of the IgG class, and IgM and IgA do not cross. And they cross going in backwards, attached to this special Fc receptor, FcRn. And because they're being pulled in by the FC region, the transfer is not based on the specificity for antigen, but just on the class of antibody. And it has been suggested that maybe if you have a pathogen bound the other end, that this is a way you could actually get pathogens across the placenta, called the Trojan horse hypothesis. Next slide. The other possibility is that we know also that there are defects in this placental barrier, and there are frequently breaks in the syncytium, and you can see that these maternal macrophages actually heal the placenta. It's rather striking that maternal cells are healing the fetal placental barrier. So it's possible that they could have crossed in these breaks, but we do have, next slide, one very important cell in the placenta, the only immune cell that the placenta has, which are these macrophages, these Hofbauer cells. And I think this may be why it is preferentially pathogens that can survive in macrophages that do cross, and that other pathogens, even if they get across this trophoblast barrier, will be phagocytosed by macrophages. We know also that they have the capacity to phagocytose pathogens. Next slide. So is there a congenital transmission, vertical transmission of SARS? And I think this is quite a useful paper to consult, where they've tried to say what would be the criteria that we would accept for agreeing that there is vertical transmission. Next slide. And I think that what this summarizes is that the difficulties in this is if one does PCR for viruses in the fetus or the placenta, there of course could be a false positive. And any baby who's been born to a mother infected, there will be virus everywhere around in the labor ward. So you have to be incredibly careful not to get contamination. Nasopharyngeal swabs have very limited use at birth because, of course, that isn't the route of transmission. In vivo, it would be via the blood. The sort of gold standard for vertical transmission is to look for IgM, specific for the pathogen, in cord blood. But the sensitivity and specificity of IgM serology tests is still not really very secure for COVID. And there are many different manufacturers that are making them, and they've really only been tested on ITU patients. So I think this is still an area that is under development. Next slide. So I think this is, again, a summary from the British study, which is a prospective study. I think it's the only really prospective study of all babies born. And what they found was really very, very low evidence of neonatal infection. It was very uncommon in the first 7 days. There was this highlight that different ethnic groups seem to be more susceptible. They said 2 possibly vertically acquired, but I think with these provisos, this jury is still out as to whether there really is ever vertical infection. If there is, it's very rare. Next slide. So I think I can finish here by summarizing that intrauterine vertical infection, because of the low levels of virus in the blood, the lack of both receptors on trophoblast cells, placental infection is very unlikely. It may still occur. You can never say never in medicine, I know. Perinatal infection, yes, that is likely to occur. Because of delivery, there will be exposure to the feces, which contain virus, and saliva, and exposure to respiratory secretions after birth. But it generally seems that it's an asymptomatic or mild disease in neonates, and it doesn't mean that you should separate the baby from the mother. So I think we can feel more confident actually that vertical infection probably does not occur. If it does, it's extremely rare. Thank you very much.
Thank you, Ashley. Thank you for this excellent presentation. We have learned a lot. And it's time now to go to the patients. And it's my pleasure to introduce Andrea Brusic. Andrea will give us some insight into what to do to support patients during the COVID-19 pandemic. And from what I've heard, she will also tell us her personal experience with the pandemic and how she has dealt with it. So please, Andrea, the floor is yours.
Do you see my presentation?
Okay, now, thank you.
Okay, thank you. I'm honored to have the opportunity to present during this webinar and to give the patients a voice. Today, I would like to give you more information about the patients in the middle of the COVID-19 pandemic. My name is Andrea Brusic and I'm from Croatia. I'm 33 years old now, and together with my partner, we are trying to conceive for almost 3 years now. We are struggling with idiopathic and unexplained infertility, and I'm volunteering for the Croatian Patient Association called RODA, Roditelji u akciji, or in English, Parents in Action, the only association in Croatia representing infertility patients. And as you can see, it's RODA 20th anniversary this year. In the beginning of pandemic, by which we were all hit, we as patients in Croatia were hit strongly and without warning over the beginning of March, when some of MAR clinics in Croatia started to reject new cycles and new stimulation treatments for IVF. On March 18th, there was an official decision issued by Croatian Minister of Health, by which all MAR treatments were to be stopped immediately. It was only 1 or 2 days after that when ESHA issued the official statement on pregnancy and conception. Since March 18th, very insecure, and for us patients, very long period began where no MAR treatments were performed in whole Croatia. Any kind of information patients in Croatia received during this period about MAR treatments, about possible closure, were coming only from patient association, forum, or Facebook groups. Generally spoken, the information flow was rather from patient to patient than from official side, from doctors or through clinics. This very dark period resulted in severe worries, overall uncertainty, and overwhelming fears among patients. It was more than a month after this when ESHA issued guidelines on reopening of MAR clinics. On 1st of May 2020, the Croatian Association for Human Reproduction issued the specific and obligatory guidelines for reopening MAR clinics, with new rules and restrictions, with testing and excluding. As of 6th of May, all clinics were officially allowed to open by a new decision from the Minister of Health. The majority of clinics opened by mid of May, although we all know that reopening in MAR means a lot of days of preparation before a cycle or stimulation for IVF can start, before the first egg retrieval will take place, before the first embryo transfer is about to happen. The Clinical Hospital Center in Rijeka did not open their department for human reproduction for new IVF treatments before the end of June 2020. This was a period of first hope because of reopening, but also despair and chaos. Even after opening, in most clinics, no telemedicine was possible. There were no or very few official information available. We as patients mostly saw new restrictions, new rules and measures. Out of a sudden, we had newly created priorities amongst patients, older female patients first, and also frozen embryo transfer from earlier interrupted cycles first. We face longer waiting lists. Now, I would like to give you more insight of my experiences during this period. Before March 2020, we were trying to conceive for over 18 months, and until this time, we have finished all our exams and were waiting for our first fertility treatment. Then the pandemic started. From mid-March until the beginning of May, There was a complete closure of all clinics in Croatia, whereas my clinic, the Clinic Hospital Center in Rijeka, was not ready to start new treatments until the end of June. In July, we finally started with our first fertility treatment, insemination, but unfortunately without success. Our happiness, because we finally started with treatments, didn't last long, because in August, the Department for Human Reproduction was closed due to collective holidays. In September, we had our first natural IVF, which turned into rescue insemination due to premature ovulation, but ended unsuccessfully. In October, we had our second natural IVF, but the only collected egg was overmatured. In November, we had a third natural IVF, but there was no egg retrieved. Finally, in December, we decided to change from the state clinic to a private clinic with reimbursement agreement with health insurance, which also meant traveling over 200 kilometers for treatment. After consultation, this private clinic put us on their waiting list until March 2021 for IVF. This first stimulated IVF treatment resulted in a biochemical pregnancy after frozen embryo transfer. I'm attending patient support groups online or Zoom, which I found very helpful and motivating. In the meantime, I also became a member and volunteer of Patient Association in Croatia, RODA. Overall speaking, due to COVID-19, we had only one stimulated IVF treatment within more than a year. But how did and still do other patients feel, and what are their fears? Some women and couples lost their last chance to try to conceive through IVF because of the pandemic. For example, the female partner became too old for reimbursement. Some women and couples are still postponing treatment and waiting for easier times to get pregnant and to become parents. There was a lot of depression and hopelessness during the lockdown, as it felt like not being able to get pregnant forever. Patients felt like they are missing support from doctors and other medical staff during the lockdown and after. A lot of patients had fears about possible impact of COVID-19 infection on male infertility. Patients were also very much afraid of infection during treatments and a potential risk of treatment being stopped, losing reimbursement or of IVF without egg retrieval, without embryo transfer, and without any chance to get pregnant. There is no time to discuss and consult with doctors and other medical staff due to the measures and avoidance of unnecessary contact. In Croatia, we are missing psychological support for infertility patients as part of fertility treatment, which means that we also had no psychological support during the pandemic. Patients in Croatia also expected collective fear of second closure of IVF clinics in autumn and winter in 2020. Patients now confused whether to get vaccinated or not before treatment or after treatment or during pregnancy. What we really wish for the future is the end of the COVID-19 pandemic. The sooner, the better. We also would like to get more support and open communication from official side, ministry, clinics, doctors, and other medical staff. We wish telemedicine forever, wherever is it possible and necessary. We would love to have psychological support for people facing infertility, and this even more during the pandemic. We suggest to increase the number of fully reimbursed MAR treatments, as 1 or 3 or 4 IVF treatments often are not enough to have at least one baby born. Shorter waiting lists for reimbursed treatments, and as fertility rates are falling in many parts of the world due to the pandemic, we suggest access to reimbursed MAR treatments for all women and to include single and lesbian women. We all know that 1 in 6 couples is facing infertility. This is why fertility and infertility has to become priority number 1 for each country in Europe. Hvala, thank you.
Thank you very much, Andrea. It has been really useful. We need to hear the patient's voice to try to adapt our services, our centers to this situation. And this is what the next speaker is going to cover: how ART services have adapted to the pandemic, And it is my pleasure to introduce Edgar Mocanu. As I said, Edgar is a member of the working group, of the SRE-COVID working group. He is a reproductive endocrinologist. He is a specialist in male and female infertility. He's a clinician performing clinical ART, and he will give us some information regarding what we have recommended and produced as guidance documents all this year in the working group. So Edgar, please, thank you for coming, and go ahead.
Chair Dr. Vega, thank you very much for the introduction. Thank you, ladies, co-speakers. Ladies and gentlemen, a pleasure being here for this second major webinar. I have small disclosures belonging to a few international professional organizations. I was asked to talk to you about how services should be reorganized, but I would like to discuss a few other things today. Firstly, the so-called COVID-19 effect, as I might call it, asks the question, is treatment a risk for our patients at this time? How we should be safeguarding patients and staff health, well-being, and of course, the health of their future children. And maybe challenge you by saying that today it appears that change in our area of work and expertise might be externally driven, and we need to pay attention and catch up with it. So what do I mean by that? We know about this continuous improvement cycle of analyzing what we do, understanding, I believe, the patient perspective as beautifully shown by our previous speaker, proposing changes to reflect the perspective of patients, implement those changes, and audit the impact of those changes and the improvements that were introduced. And many times we tend to lag behind what our patients need. But there is this event that happened last year called COVID-19, and I believe that this induced significant adaptation to the way we provide services. And this green arrow basically says that there's additional spin in this circle, and unless we are going at the speed required, many services will be left behind. So is treatment a risk currently? I will present a few papers, not a lot. This is not about a lot of science today, but just to draw your attention to the male field, the female field, and maybe looking at the early human embryo, as this is the area we're working in. So this paper from Italy, published just recently with Advanced Access in February, looked at men that were diagnosed with COVID. And you can see here the flow diagram, and in the end, they looked at 43 patients that were interested in participating, having been diagnosed with COVID and being willing to provide a semen sample. And the amazing finding was that after recovery from COVID-19, 25%, that's 1 in 4, 11 men had semen impairment. 8 were azoospermic. This is 8 men out of 11 were azoospermic, no sperm in the ejaculate, and 3 were oligozoospermic. Furthermore, a large percentage of these men showed pathological levels of interleukin-8 in semen. So the first conclusion is that the previous infection with COVID-19 will affect spermatogenesis significantly. Yet the authors give reassurance. All the samples from the post-ejaculation urine semen sample, pre-ejaculation urine, were negative for the virus. So that is reassuring for our patients that want to know if the virus can be easily identified in the ejaculate, or does it integrate in the sperm. I think this information is here for a longer period of time. In 2020, the French-speaking Society of Andrology produced some guidelines that had practical applications. Firstly, they observed that the Leydig cells in the testicle express both receptors, the ACE2 and also the transmembrane ring protease, beautifully illustrated by Dr. Moffat earlier. And they concluded that it is possible that testosterone production and secretion is impaired in patients that were infected with the SARS-CoV-2. They furthermore gave strict instructions as to the wisdom of renewing air between patients in the semen sampling room, but also on wearing a mask during retrieval and strict rules of cleaning laboratories and particularly the semen sample rooms after a sample was produced. So just to wrap up the male evidence, we truly have no strong evidence to suggest that a couple should avoid intercourse because of risk of contamination or vertical transmission. We have no convincing evidence that the virus is present in the ejaculate. And there is a suggestion that males that have been recently diagnosed with COVID-19 should consider avoiding ART for 3 months, mainly due to the disease burden, fever, hormonal impact, and as I've just showed you, the possibility that semen parameters will be severely altered, thus requiring the need, for example, to use ICSI, and maybe waiting for a little while, semen parameters will improve. And of course, that hygiene measures should be rigorous in our services. This question of receptors in the and proteases in the reproductive tissue is still one that has no final answer. This is a paper from a group in Germany and a group in the United States that looked specifically at single-cell RNA expression, and this is mined data. Mined, it means it's taken from databases. And if you look at the human ovary here on the right-hand side, you can observe that the human ovary, while indeed it has expression of ACE2 receptor, has no expression of the transmembrane serine protease receptor. Thus, the likelihood that the virus could integrate into the ovarian tissue is negligible. From a practical perspective, during the IVF, 2 questions are important. One is, can the virus be identified in the follicular fluid? And the second, can the viral RNA be identified in the oocyte? And this have been answered with these studies. Now, I do acknowledge they're pioneer studies, very first ones, and numbers are extremely low. So 2 women and 2 women, but there was no evidence that viral RNA is present in follicular aspirates from SARS-CoV-2 positive women undergoing IVF. Neither were the authors from Spain able to identify viral RNA in oocytes, again, from women that had IVF while they were infected with the SARS-CoV-2 virus. And maybe what Dr. Moffat suggested or showed, the fact that the viral concentration in blood is far lower than in the upper respiratory tract might be the reason why we fail to detect the RNA, and hopefully these tissues and fluids are not a source of viral RNA. So the oocyte does not appear to have the proteases entry factors that facilitate cell entry for the SARS-CoV-2 virus, and this suggests the oocyte might be protected against the infection. And what about the human embryo? And the same group looked at this very detailed analysis, and I'd like to draw your attention to the right-hand side of this picture, where you can see here the main ACE2 receptor, and then further down the transmembrane protease, serine protease. And remember, they have to be both present for the virus to unlock the door and enter a specific tissue. So at the top is the stage of development from the oocyte up to the morula, and then blastocyst with inner cell mass, trophectoderm, and so on and so forth. And you can see that ACE2 receptor is indeed present in the oocyte, in the early embryo, the zygote, in the 2 and 4 cell embryo, weakened in the 8th cell, not present in the morula, and then starts appearing again in the inner cell mass and trophectoderm, quite expressed in the trophectoderm. By contrast, the transmembrane serine protease is totally absent up to the blastocyst stage. So basically, while one is there, the second isn't for the very early development of the embryo. And this is when embryos are in our IVF laboratories. So this offers significant reassurance, at least in theory, based on RNA databases, that only at this stage of the very early blastocyst, there is the theoretical possibility that the virus could enter the blastocyst, particularly at the level of the trophectoderm. And if you look at the inner cell mass, the expression is not that significant. It's only yellow. So yes, trophectoderm, some evidence that there's a theoretical possibility for the virus to integrate. And while the German-American study showed that, another large study from China looked exactly at the same thing. And as you can see here on the left-hand side, oocyte, zygote, 2-cell, 4-cell, 8-cell, Moorline blastocyst, ACE2 well expressed, then nearly not expressed in morula, and then in early blastocyst showing up. And you can see the transmembrane receptor completely absent in the early human embryo up to the stage of morula, when it has a very modest increase, but then really increasing in the blastocyst. So it's definitely at this stage that the susceptibility for a viral infection becomes real. But then we have to remember that we are transferring those embryos quite early, so maybe the risk is negligible. Interestingly, this group from Wuhan Institute of Reproductive Health and the medical college, local medical college, suggested some changes which I think sometimes are a bit harsh, and they're the one in red. But they propose that fertility preservation for COVID-19 is relatively safe and rational, based on exactly what we said, that the co-expression is not there. And they also suggested that embryo preservation and embryo transfer into healthy recipient mother should happen at the cleavage stage, before the embryo has an opportunity to reach the blastocyst stage and both proteins be expressed. But what I thought was extremely interesting is that they draw the conclusion that it is possible that the data, the mRNA data from the rhesus monkey, mouse, and human embryos, or pre-implantation human embryos, is not translatable. In other words, what is valid in monkeys and mouse might not be true in real human tissue, which we have no information to date, obviously, about. So to conclude on human embryos, express both the ACE2 and the transmembrane gene from day 6 onwards. They're unlikely to be susceptible to the SARS-CoV-2 infection. The post-implantation early human embryos could be susceptible, and all the data is based on RNA expression and not validated at protein level. So what should we do based on this information? How do we safeguard patients' and staff's health and the future health of children conceived? And of course, adaptation of services is key. And I would like to show you this paper, which I found the most amazing publication that I read on the virus. And this is a multi-group collaboration, mainly based in Max Planck Institute in Germany, where they showed how adaptive this virus is. And let me just show you this on the right-hand side. Of course, this is the virus here that has an ankle, a knee, and a hip. It's like a stepping giant. And the reason why it's important to understand this is that the configuration of the receptor, this is the S protein, is essential in their ability to attach to human tissues and cells. So if you see here on the right-hand side, virus is this circle, and their receptors, by changing the angles of this ankle, knee, and hip, could adapt to touching or reaching more ACE receptors than if this will be a rigid stick, so to speak. A rigid stick will just catch maybe one. But because they can adapt, you now have 4 S proteins touching on 3 receptors. So it's highly stickable. Stickable, that doesn't exist as a word, but it sticks phenomenally better than other viruses. So if the virus can adapt, can you imagine how much adaptation we need to do to catch up with this virus? And there's no denial that the pandemic has severely affected access, with reduced number of patients attending in order to ensure safety, with reduction in staff present and the creation of teams of staff providing care, and with delays in starting therapy as a consequence. And of course, patients are affected by that. So how can we increase the volume, and how can we make it better? Well, firstly is the triage. And the triage questionnaire has been published by Escher before, and it still, I think, forms the foundation of everything we do in terms of risk reduction. And there's just three possibilities. The staff, patient, partner are asymptomatic, and the triage is negative, so move on, have the therapy. The staff, the patient, or the partners might have mild or maybe not specific symptoms, and they are positive on triage. In that case, test for the SARS-CoV-2. And I'm not going to go into details. RT-PCR or antigen testing, whatever is available, whatever your laboratories can provide you, whatever your virologist can advise you. And if the test is negative, move on, but be open-minded that the scenario could change. And if the test is positive, then exclude from treatment. And the third possibility is that patients or partners or staff have symptoms and or a previous COVID-19 positive test, and this is a triage positive, and then we exclude them from therapy, and we delay for the duration of the 2 weeks that is normally accepted. So what do we specifically do? Sorry, I'll go back to this. So this is actually called the ACT diagram in all our publications. So that's how we like you to remember it. Well, how about staff assessment? What has changed? And in terms of staff, and here I'm acknowledging that maybe not many patients might have received in all European countries the vaccine, but one expects that frontline staff would have received it. So if the staff is vaccinated for COVID-19, then it's okay to go for work. It's a yes, it's a green light, so attend to work. But if they have not received the vaccination, then routinely we have to do the COVID test every 2 weeks, again, PCR or the antigen. And if there's no evidence of infection, proceed with work. If there is infection, occupational health advice and self-quarantine. And in between interval, the triage questionnaire may be asked every week, how do you feel, is everything okay, or maybe even more common than that. And then apply the ACT diagram that I've just showed you a minute before. Similarly, during the treatment, we segregated, and we believe that this diagram is clear and easy to follow. So here on the left-hand side are the prerequisites. So patients with previous, this is the ART treatment at the top, so 2 weeks prior to the start of the ART treatment, patients with previous COVID disease and SARS-CoV immune or vaccinated for COVID-19. If this answer is yes, then they can follow a standard procedure with a provision that things will change depending on what's happening during the treatment. But if the answer is no, then we have to test them for SARS-CoV-2, either with PCR or antigen testing. And then if they're positive, delay their treatment. And if they're negative, we move into the standard procedures for the start of therapy. At the start of ovulation, we apply again a questionnaire and use the ACT diagram depending on their symptomatology and the answer to the triage questionnaire. And if everything is good, they continue to the next step in terms of trigger and egg collection. If the answer is they become high risk, scenario 3, postpone the treatment and stop any subsequent steps. And scenario 2, then continue, test for SARS-CoV. This is keep an open mind, test for SARS-CoV whenever it's needed before the egg collection. If negative, have the egg collection or the start for a frozen embryo transfer. And if positive, then delay the treatment. And what we thought will be interesting and very helpful for all practitioners is this part here. And although it looks a bit neglected in gray, we believe it's a very important step, and that is to ask patients, how are you? What happened after we did the transfer? So this is the follow-up 2 weeks after the transfer. We ask them, are you okay? Did you get infected? What is the state of health? So that will add to our knowledge and understanding. So I will provoke you with a few thoughts before I finish. Firstly, I think COVID-19, despite creating such a challenge for both patients and practitioners, I think it raised a few opportunities for us to rethink what we do. Firstly, we have to accept that life on Earth remains dangerous. We have many other challenges on Earth apart from COVID-19, and indeed, we have to try to survive for many millennia, hopefully. But the lockdown has a reproductive impact that is not necessarily related to COVID-19. The stress, which was mentioned by our previous speaker, the increase in obesity, people are staying at home, they don't really exercise a lot, the stress increases the risk of obesity, alcohol and substance abuse, the lack of exercise, and of course, pollution. So I think when we look at services, the remote access mentioned before and the simplification of processes will have a significant role to play. So apart from the COVID-19 adaptation, I see how in the future the ART services will require radical adaptation. And I'm not pretending to predict the future, but this is already happening. From diagnosis, a treatment plan now can be organized online, the prescription could be sent online. Sometimes in the future, maybe 2-3 years, patients could have their stimulation monitoring at home. There are now devices that are can be used at home, where a scan can be performed by the woman in the comfort of her own home with the image sent to the practitioner and a decision being made. A theater environment could be fully controlled, and then the laboratory one day might be less human intensive and more human supervised and ART controlled and fully automated, thus reducing the risk of contamination and so on. So I think by saying that we can see past the pandemic, I want to say that although we feel severely restricted in our freedoms, I think the adaptation has been severely accelerated, a positive thing. We are reassured that there's no evidence the virus has any long-term impact, but we acknowledge that patients are suffering due to limited access. And I think the future holds a few surprises for us in terms of supply of services, in terms of demand increased, in terms of affordability. The societal changes could create a lack of affordability, and the market forces with a new model that I just presented to you. So I think the opportunities are within reach. I will say that we still have to prove harm, no harm of the disease to ensure the services continue and offer a voice both to practitioners and patients, to support each other and bring the scientific evidence, to support our patients by working together and improve our practice by studying new aspects. So to quote this famous French artist, our Spanish artist, I would say, have no fear of perfection, you'll never reach it. Let's work towards it. I'd like to say thank you to you all, and also acknowledge, and I know Anna mentioned this in the beginning, but I'd like to acknowledge this hardworking group, and there are pictures of all of them coming from Spain, Finland, Sweden, Italy, Central Europe, Turkey, and a central office there, Natalie, that is working very hard supporting this team that brings to you some new developments and has supported you so much, we hope, in your activities and providing the services. Thank you.
Thank you, Edgar. This was an excellent presentation, as the other ones. And now there's time. We have almost 20 minutes for questions. I have a number of questions that have been put on the Slido application. The first questions probably go to the first speaker, so I will start. With respect to the vaccination, there is one question asking, what is your opinion about extending the time of the second dose? And this probably goes to Kari Johansson. Kari, are you there?
Yes, I'm sorry, it was difficult.
Okay.
The unmute button didn't respond first. If I understand the question, it's about extension of the between the two doses.
Yes.
Clarence Sigrist is my god of immunization, professor of immunology and pediatrics in Geneva. She teaches that you should have a minimum of 4 months between priming and booster. So all the childhood vaccines, they have 1, 2, or 3 priming doses, and then you have a period of minimum 4 months for a booster. And priming, for some of the excellent vaccines, it's enough with 1 dose. So this is, if we view these vaccines as very good primers, and I think we can, 1 dose is enough, and 4 weeks is really too early for a booster, according to what we are taught for the pediatric vaccines. And so I think it's a very good idea to have a longer period, but it depends on the epidemiologic circumstances. If there's a lot of virus circulation, you have to provide the 2nd dose earlier. The 2nd dose offers better protection in the range of, say, anywhere between 10 and 30% better, depending on who you are, if you are a good responder or a poor responder to the vaccine, depending on age. And I think it's a very good idea to try. And there are studies ongoing, and the 2 studies I'm aware of is in Oxford, where they do what they call mix and match. So they use 1 vaccine for priming, another for the 2nd dose, and they do it vice versa. And they have 4 weeks in between or 12 weeks in between, and look at antibody development. And data will become available from around the 21st, 22nd of May. And we are really looking forward to it, but that will only be the 4-week period. Before we have the 12-week period, will be midsummer or August. So we still have so much to learn about these vaccines.
Thank you. It's true. We still have so much to learn, not only about the vaccines, but about the virus itself. And going to the second question. Just a minute. I'm here. The second question is, azoospermia detected how long after the infection? This is probably for Dr. Mocanu. A male factor seems to be affected by the infection, and probably the one that asks the question wonders how long do we have to wait, and if this azoospermia can be recovered, which you showed also in your data that you collect.
Yes, the paper looks at results after a month and a half from the moment of infection. They didn't look how long it will take for the azoospermia to disappear, because they actually did just 1 semen sample, initial semen sample. But it makes sense to believe that once the virus starts being cleared from our blood and from our testicles, that the spermatogenesis could kick in. So 72 days, 3 months afterwards, one would expect a return to normality, I would believe. But there's no specific study that looks at, diagnose you with azoospermia today, we follow you every 3 months for a year, and then we establish exactly when your spermatogenesis has returned to normal.
Okay, thank you. Let me see. I'm not following exactly the order of the questions, but there is one question that I want to consider. And they say that an anonymous person says that I saw that ESRE changed position, no more antibody testing. It is confusing. It is important for professionals that are, have clear recommendations, and probably we need to pay attention to that, because as you see that everything is changing so fast. The information that we get, not only with regards to the virus, but with regards to the vaccination and to the testing, makes it very difficult to make recommendations that do not change over time. But maybe, Edgar, can you explain why we are not basing our screening on the antibody testing anymore, and we are recommending other ways of assessing if the person is infected or not?
Yes, and thank you, Anna. I think you're absolutely right. It's basically catching up with what the evidence, evidence emerges. So we cannot stay caught in the past. Antibodies at one moment in time are to diagnose an acute event or to diagnose the presence of immunity. So in order to make it more accessible for patients and more accessible for services. I mean, in Ireland now, Lidl is selling antigens. You can go to Lidl, buy your antigen, and have a test at home to find out if you have the SARS-CoV-2. I think that's one of the reasons. They're highly accurate, they're easy to do, and we get an immediate result, point of treatment result. So that's one. That question also asked, where is this information? And I think for the people that have decided to register, believe it or not, this information is for the first time presented here because we've just signed on this document and it will be possibly put on the website tomorrow. So you've got it first as a simplified, a streamlined guide to make it easy for everybody to understand how you should monitor and adapt your treatment. Now, obviously, different centers and different countries might have less or more access to antigens, less or more access to antibody testing, less or more access to PCR testing. We're not providing a 100% foolproof algorithm for everybody to follow. We're just giving guidance on what we believe it will be simple, straightforward for practitioners and patients. Thank you.
Thank you. I have a question for our patient representative, for Andrea Brusik, and it seems that you complain a little bit about the lack of guidance and the lack of support from the clinicians, from the doctors, from the staff of the clinics. Has the Association of Patients been of any help in trying to guide you, and to which recommendations have they been attached to try to guide the patients, and what do you think it would be good for the patients associations in terms of recommendations? We try to provide clear recommendations, but we see that sometimes we don't succeed in giving a very clear message. So can you tell us, and I'm sure that there are many professionals listening to our webinar, what can we do to try to help you to deal with all this? What would be your proposal? We cannot hear you. You are unmuted.
Now?
Now.
Okay. I think that in that time we expected from our clinic where we were in the treatment, we from them expected some informations and what and how we should do in that time. And on my experiences was when I called hospital, they didn't have any clear informations. They were all perhaps this, maybe that, we don't know, we didn't became clear informations. So they push their responsibility of the Ministry of Health. And then in these Zoom meetings with other patients, we were sharing informations. This clinic says this, that, and we were all in waiting. And I think that in that moment for us, the best would be that we had some maybe web page that we directly could reach really true and informations in a right time. We didn't know how time we should wait, when the treatments would continue. We didn't know nothing.
Okay, so information and support from the medical doctors and from the nurses to know exactly what to do. Okay, yes. Thank you. There is a question for Ashley Moffat. You said that Probably vertical transmission is very infrequent. In fact, I think that you mentioned that in only 2 cases it could be not demonstrated, but more evident than in the others. And there is an anonymous person that asks if you know how the babies that were COVID positive acquired the disease. If they acquired it in utero, which one of the 2 possibilities you think is the most probable?
So I don't quite think I've understood the question. Which of the 2 possibilities? Sorry.
You said that it could come from the blood through the syncytium, and the other one was, let me see.
Oh yes, I see. Yes, I think personally, and again, it's rather amazing that we know so little about the basic biology of this. Is that that most vertical infections do go from blood across the syncytium. But there are some, and it's Zika's one actually, and Listeria, which may actually infect the decidua and go across from the extravillus. But this is a very difficult area to investigate because, of course, the human placenta is quite different than the mouse, which is the experimental model that people would use. And for example, mice placenta, they don't have any placental macrophages. The structure is utterly different. They don't have a syncytium and an intervillus space. It's a labyrinth. So we can't really use the mouse for this kind of experiment. So I think we don't know. And one of the sort of challenges for me when you asked me to think about this was how little we know. You know, how the idea that antibodies could carry it across, you know, that has been around for a long time, but nobody's ever really worked on it, actually. So I'm sorry, I'm speaking that there are a lot of unknowns about this, but I think what the optimistic thing is that it looks very, very rare that it does go across, and I think babies can pick it up at delivery. That's certainly likely to be possible, but it doesn't seem a very severe disease, even if they do. If the mother is vaccinated early enough, antibodies will cross the placenta and the baby will, or the IgG antibodies will cross, and the baby will have some protective antibodies.
And let me go a little bit more in detail into that. If the mother has a severe disease, okay, and the placenta is infected, would you expect to have a deterioration of that placenta that will compromise embryo development?
Yeah, so that these rare cases, which I showed you the photograph of, and again, they are rare, they're sort of case reports, and there haven't really been enough case control studies because you can see this anyway at the end of pregnancy. But in women who've been very sick, you know, on ventilators or ECMO, then they have seen this inflammatory infiltrate in the intervillus space. And that can trigger a disorder like preeclampsia, because preeclampsia is, of course, caused by a stress to the syncytium. But normally, preeclampsia is because the stress is because the blood flow is not enough. It's hypoxic, really, stress. But this is a different kind of stress to the syncytium, and we see that in placental malaria. And in placental malaria too, you do see growth restriction. So it is possible that you could get some effects like that the baby may not grow properly because of this inflammation in the intervillus space. But I stress this is rare. This is only in the very, very sick women. This is not going to happen in just in an ordinary infection.
There's also there are also questions regarding how long do we have to wait after the vaccination to start an IVF treatment or an ART treatment, and how long do we have to wait after a disease, a COVID-infected patient to go for treatment. And this also applies to donors, as you perfectly know. We treat many of our patients with oocyte and with sperm donation, And I think this is an important issue to be considered. So maybe Edgar, you could you tell us what could be the recommendation? So after COVID infection, how long does a couple have to wait until the treatment, and how long after vaccination?
Yes, Anna, thank you. After COVID, obviously, countries will recommend observation and 2 weeks of isolation. So it is expected that after 2 weeks, firstly, the risk of contaminating others, including other patients and staff, will be negligible, and the patient could return for treatment. Yet, as I've just showed you, there is evidence that male COVID infection will affect spermatogenesis. So I think there is an argument for monitoring sperm parameters and maybe return to treatment once the spermatogenesis has improved. In terms of the female, truly nobody knows. If we consider that the oocyte maturation lasts 200 days, an episode of a SARS-CoV infection for a week or two will have a very small impact, one believes, in terms of the quality of the eggs in IVF. Yet we have no data. Nobody has published any study that looks at women treated during COVID-19 infection, and particularly women that have to have an egg collection, like oncology, cryopreservation, and what is the quality of the eggs. And there will be interesting studies to look at as the only comparison, because all the other patients would have been stopped prior to the egg collection if they had a positive test before the trigger. In terms of vaccination, once again, we have no idea. Vaccination is just being rolled out around the world in the last few months. So do we have strong data on the impact, for example, of the immune response upon embryo implantation? We don't know. Is it possible that the immune system, and we've seen beautifully, Dr. Johansson showed that, how the T cells and the B cells are activated. So is it possible that immediately after vaccination there is an increased spike in immune response? Very likely, that's what vaccines should do. But does this affect the early embryo implantation in IVF? We don't know. So I think waiting for maybe up to the next period after the vaccination, maybe 2 weeks or 3 weeks, is reasonable, just to be on the safe side.
Can I just come in there? Because actually in the lining of the uterus at the time of implantation, there really are no B cells. There are very, very tiny numbers of B cells in the basal aggregate. So I don't think that, and there are very few T cells, actually. T cells are kept out. So the dominant cells there are NK cells and macrophages. I think it's highly unlikely that the vaccine will affect the immune system in the decidua.
Thank you for the clarification. Andrea, I would like to ask you one question. We have had, let's say, complaints from patients and from patients' associations, because we recommended stopping ART services, because we recommended caution in doing certain procedures. Do you have the impression that patients that want to get pregnant are really aware that maybe a difference of 2 or 3 months would not make a very big difference in terms of what they can achieve?
Of course. For example, I'm now 33 years old, and for me it's honestly not big problem. But for example, for women with 39, 40 years, because in Croatia the law is that you can, with the government help, go to IVF treatment, you lose with 41, and then some women were on the border to lose the right to have paid IVF treatments. So, and also with the time we are afraid that our chances to get pregnant is lesser and lesser, and all that affect our thinking about waiting. And But now when you speak about the reasonable facts, of course.
And obviously support is needed to those patients, so everybody understand what the situation is and how we can help them. Let me finish, because it's time to finish now. Let me finish by asking a question with regards to vaccination and pregnancy. There has been a lot of discussion about this. We haven't had any data up to now, well, very limited data with regards to the safety of the vaccine in pregnant patients, which seems to be the case. But why do you think that pregnant patients have to be vaccinated or not? Kari, what is your opinion with regards to that?
So I'd like to go back about 2 months in time when Israel started reporting a higher number of pregnant women in intensive care. Before Christmas, they said they had around 5 to 10 women in intensive care, while in February they had around 50 individuals. And this has been observed in a few more countries. I don't know if anyone really collects data, maybe you do. So they really wanted to start vaccination, and they started vaccination during pregnancy. Ideally, I think it's always, especially with new vaccines, it's better to vaccinate before pregnancy. So you are through, if you have the time and the age with you, so you can wait, it is better to be fully vaccinated before. And you develop an immune response about 2 weeks after second dose, or of course you develop an immune response already after the first dose, but you have a good immune response after 2 weeks after the second dose. And that's the cutoff we have for the effectiveness studies. But this may not be practical everywhere, so it has to be developed and discussed with a responsible clinician wherever you are.
Okay, thank you. I think we are now the webinar is over. Let me finish by thanking again all the speakers. I have learned a lot. It has been an excellent contributions. I also thank the audience. I'm sorry we have not been able to address all the questions that were there. You know that there is also the possibility to put the questions on our website. We will try either to reply to them from the working group, or we will try to get the expert's voice to reply to them. Thanks again to ESHRE, to the central office, and again, thanks a lot to Natalie, who is, I would say, the spirit of our working group, and who is the one that makes us work a little bit to try to improve what we know about this virus and how to deal with it in ART patients. So thanks a lot, and
Thank you.
maybe see you soon. Thank you.
Thank you.
Thank you.
Thank you.
Bye-bye.
Are you there, Natalie? Yes. I cannot see you. Oh.